to move things forward now, we're going to get into a little review of the medications. And from Virginia Garcia and Pacific University School of Pharmacy, we have the fabulous Bridget Bradley. I think most of you guys have seen Bridget present before at previous sessions. So, Bridget, would you like to take it away? Please give her a big round of applause.
Thank you all. So good morning. I was excited to be brought back to do this session because this is actually what I do at Virginia Garcia. So I'm a psychiatric pharmacist. So I think I told you guys this before, but I graduated from Oregon State and I did a year of residency at the Roseburg VA down in Roseburg, and then I did a second year residency in Sioux Falls, South Dakota at a 110-bed standalone psychiatric hospital. And since that time, I've been back here in Oregon, which is where I'm from, and I've been teaching at Pacific University, and this is the start of my 5th year. And in January, I will be down in Virginia Garcia for 5 years as well. So this is what I do in Virginia Garcia. So I'm excited to hear from you guys and just kind of share a little bit of hopefully some tips and some ideas about antidepressants. So again, I see patients for depression. So I know a lot of you guys are in primary care settings. So do any of the nurses do depression management or check-ins for patients? So a couple, I know at Virginia Garcia, a lot of the nurses did the impact training a couple years ago. Did you guys do the impact training? Okay. So hopefully for some of you, this may be a review, but when we're treating patients for depression, our first goal is to improve those acute symptoms. So that initial suffering of depressed mood, loss of interest, a lot of the other symptoms that go along with depression. And we'll go more deeply into the PHQ-9, which was mentioned before, and kind of how I use that as a tool in my primary care clinic to assess for medication, that the medication is working or not working, or changing medication doses. And there's a little bit of guidance here in the slides with that as well. Hopefully we're going to achieve remission, and I think it was really good. And even as a pharmacist, I'm going to repeat that medications very rarely get people to remission on their own. So hopefully in our primary care clinic, I know our physicians and myself, we're always encouraging patients to engage with behavioral health therapy, engage with counseling, because we know that that is, the combination is where we usually really get those remission responses that we're looking for. And then hopefully preventing further episodes or recurrence of their depression. So how many of you guys use the PHQ-9 in your clinic? So just a couple people, how are you guys using it? Yeah.
With somebody who's diagnosed with depression, we're using it with every visit.
Okay. So she said, so patients that are diagnosed with depression, they're giving the PHQ-9 at every visit. Okay, so even for a diabetes visit or?
Theoretically, they're supposed to be getting
Yeah. Theoretically, they're supposed to be getting it at every visit. All right, anybody else do something similar, different?
We do a social screen annually with all the patients, and if it's positive for some questions with depression, then they get the PHQ-9 and then would have it subsequently for follow-up visits.
Okay, so it sounds like you're probably doing the PHQ-2, the first two questions.
Yes.
The decreased interest in depression. Okay. So the social screening that their clinic does, it sounds like it's the PHQ-2, so those first two screening questions, and if the patient screens positive, they get the full PHQ-9. Okay, very similar to what we do in our clinic as well. So this is just the first 5 questions. In your handout, you have the full PHQ-9, and what I have done in clinic is I have these laminated, and then I give them to my patients with a little dry erase marker so that they can mark it up, and then we discuss it. My biggest thing with the PHQ-9 is for myself, if the patient is having it filled out, make sure you use it, because there's nothing worse for a patient than to fill out a questionnaire and to sit there, the visit get completed, and then nobody has asked them about it. And then another worst part is the last question is about suicidal thoughts. So if they did click, they checked like, yes, I'm having thoughts every day, and nobody asked them, that may have been the initial time that they were asking for help, and then they thought it was being ignored. So if you're using it, make sure that you're asking about the questions. Does anybody have any other use with the PHQ-9? Have you had good success with it? Do you feel that you're using it in clinic? Yeah.
We use it as part of depression care management with every visit to see, can show the patients how they're doing. That's kind of the tool.
So using it with every visit to hopefully show the patient that the changes are happening. Yeah.
Also using it at every visit if somebody's on meds to kind of tease out if that med is having certain side effects that maybe they haven't identified.
Yeah, so possibly using it for side effects as well. Any specific questions you're really teasing out for with side effects?
Maybe sleeping
Yeah.
questions. If somebody's on Effexor or something, they're not sleeping well at night, or when are they taking it?
Yeah.
Is that an issue?
Yeah, so it can be used a little bit for side effects. There's some questions about sleeping or even concentration. Sometimes that could be an issue if somebody's taking something that's sedating in the morning. So there's some use for side effects as well. But really good for kind of looking at medications and kind of seeing that incremental changes for patients so they kind of see if the medication is working or if the medication's not working. Yeah.
Sometimes I'll have patients for a different visit, and just some of those things that they bring out during that visit, some of those symptoms where it sounds like there might be some depression going on, and I'll give it to them to just kind of tease out whether or not there is some depression going on, but that discussion is not depression.
Yeah, so even if the patient's not there for a depression visit, but you as the nurse is picking up on, hey, they're talking about some decreased interest, they're kind of talking about depressed mood, insomnia, different things that are kind of triggering you, definitely can give this to them, and the physician can use it to make a diagnosis if they find it appropriate. Yeah.
With OB patients, if they have a history of depression, I do that throughout the pregnancy, and for OB patients with no history of depression, I'll start tracking like in the last trimester and then always at the 6-week postpartum visit. And for moms with a history of depression with the new babies when they transfer over to primary care, the risk of postpartum depression is up to a year afterwards, so it's a good idea to track.
Yeah, excellent. So talking about using it for pregnancy, postpartum depression. So we have a few slides about postpartum depression at the end of this discussion. I think our clinic uses a PHQ-9, but we also use the Edinburgh. Yeah, so either one is fine. The Edinburgh's is a little more specific to pregnancy. Oh, the rest of them are there. Nice. And so this is also validated. Sorry, to go back about the PHQ-9. Our clinic, we have a lot of Spanish-speaking patients, and I don't know other clinics kind of makeups, but this is validated in a lot of languages, specifically Spanish. So if you have the English version and you need a different language, you can find them online and can print them off in whatever languages they're validated. It's a ton. It's also validated over the phone. So telephonic visits can be completed because it is validated over the phone as a measure. Then there's add up the numbers, and then the total score indicates kind of their depression severity. I think the other thing to consider with this is just a score. We're also always talking to the patient. So I also have students in clinic and teach this in the classroom, and making sure that you don't rely solely on this. If somebody's telling you they're severely depressed and you're seeing that, but their score says 5, use what the patient is telling you. This is not a be-all, end-all screening tool. So some ideas for treatment. So this is actually from the primary care treatment guidelines that Dr. Bischof showed. So if you don't have access to those, they're readily available online. But this is from that information, just an idea of therapeutic options based on their PHQ-9 severity. So our medications can come in with moderate depression, but also encouraging the counseling and the therapy, and then up to the moderately to severe or severe depression, usually combining the two and using pharmacotherapy. And then this is where it can be helpful to do those PHQ-9s at each visit, as it sounds like some of the clinics are doing specifically for depression, to kind of look for some changes with the pharmacotherapy. So the recommendation is if they've had a decrease of their PHQ-9 by 5 or more points, that signals that the therapy, whichever it is, pharmacotherapy or psychotherapy, is effective and that we probably don't need to make any treatment change at this point. If it's a 2 to 4 points, this is where we're looking at maybe increasing the medication dose. If we're having drop of 1 point or no change, this is where maybe the medication's not the right one for the patient and we're gonna change. Again, this is just a guide. We're gonna use our clinical expertise and what the patient's telling us as well. And these are changes that we're expecting in that 4 to 6 week range. So if you're following up with the patient after 2 weeks to do a dose titration, you might not see these changes. So these are that 4 to 6 week time frame. Have you guys seen this one before? Kind of the medication and therapy adjustments based on PHQ-9? Some heads shaking, yes. So there's a couple other screening tools that can be used. There's the QIDS SR16. Does any clinic use this one? Ever seen this one? This one's a bit longer, 16 questions instead of the PHQ-9. This one has gotten a little bit more use because this was the screening tool that was used in the STAR-D trial, which we'll talk about. So that was the sequence treatment alternatives to depression, the big NIH study that looked at depression management. So the QIDS was the rating scale that was used in that trial. And these are in your handout section of your folder. The Beck Depression Inventory. Anybody seen or used this one? Some shaking your heads, yeah. In primary care or a different setting? Substance abuse. Yeah, when I was at the VA, we used this for patients with chronic pain and depression. Again, a little bit, few more questions than the PHQ-9, not as a quick of a screening tool, but these are two other options that you may see when we're looking for depression or monitoring depression. Our treatment phases of depression, again, we've got that acute phase where we're looking to improve our acute symptoms of depression, and that's usually that 6 to 12 week range where we're hoping to get some response, which is we define, or it's defined as a 50% reduction in symptoms. So one way we can do that is looking at the PHQ-9 or another validated rating scale. Or remission. So that would be absence of symptoms or minimal symptoms. So a PHQ-9 score of 0 to 4 would qualify as remission. This is where it seems like that acute phase, so after that 12 weeks or maybe the patient is not having symptoms, what sometimes happens? Yeah, they stop their meds. Which is not ideal because we just got through that acute phase. We really want to get into that continuation phase. So we want to continue on their medications for up to that 6 to 9 months, especially if it was a first episode, so that we're preventing a relapse. So we're preventing another episode of depression. And then we get to that full recovery. Does that make sense? So kind of that continuing to check in. I think we, in primary care, do a really good job in that initial of, really helping the patient to start their medication, keep on that medication, look to see the improvement. But once they start improving, kind of forget that check-in with the patient of continuing your medication. And then the other step of when can you stop the medication is also the piece that sometimes gets forgotten. So there is the maintenance phase. So this is for patients, sometimes we continue medications for up to a year or even longer, but that's usually reserved for patients that have had multiple episodes of depression or suicide attempts where their depression is severe enough that we probably need to keep them on the medication for a little while, or therapy or whatever is working for them. But the biggest time is that acute phase where people stop their medication because they're feeling better. And the risk we run is they have a relapse and then we have to kind of start all over again. So it's that education piece of the medication takes, that 6 weeks to work, and then the literature supports for patients to stay on it for that 6 to 9 months. So these are the acute phase. This is helpful, especially with our antidepressants. What are some patients' complaints when they start antidepressants? So yeah, so their depression can increase initially sometimes, or they can start kind of feeling worse when they start the antidepressant. What else? What's wrong with our antidepressants? So side effects. Also how they don't work very quickly, right? People are used to hypertension, diabetes, where you start a medication, you take it, hypertension, a week later you can check your blood pressure and it's better, it's at goal, it's improved. Or diabetes, you take your insulin, you check your blood sugar, it's better. We don't get that with our antidepressants. And again, I think it goes back to the first part of our session where we don't really know everything that's going on. This is just one piece, and I'm focusing on the pharmacotherapy, but I do not think that this is the be-all end-all for depression treatment. But we don't see that remission as quickly as we would like. So we need to, when we start patients on medications or we're seeing them in clinic, reinforce that it takes some time. What we can see sometimes in those initial weeks is that first week or two, patients, if the medication is working, we do see that we'll sometimes see the sleep improve first, or their appetite if they're having those symptoms with their depression. So that's kind of our first marker that, hey, this medication might be working, their depression might be improving. Week 3 is when we might see some improvement in energy, and then it's at week 4 or 6 where we're seeing hopefully that improvement in their mood. So I use this in clinic with patients, just letting them know that, although we know the medication is going to take a little while to work, what we're going to be watching for that first 1 to 3 weeks is that hopefully your appetite is improving and maybe your sleep and some energy, so that at least they have something to kind of look for and know what to expect from the medication, so they don't get frustrated after 2 weeks and stop it, which does happen. And then our continuation phase we mentioned, and then the maintenance phase. Again, not all patients have to stay on their antidepressants for years and years. We should also be looking for our patients that we can taper off the antidepressant and see how they're doing. So this is the pharmacy love right here, all of our medications for antidepressants. And as Dr. Bischof mentioned, they have grown in the last years, and we have far, hopefully more effective, but at least safer medication treatments for depression. So since I graduated pharmacy school, I was lucky to be in the realm where we had SSRIs and SNRIs. So personally, I've never really seen TCAs used for depression. So what are they used for now? Sleep, neuropathic pain, and what doses are we using? Yeah, 10 milligrams, 25 milligrams, 50 milligrams. So we're not using those doses where we're in that realm where a patient could overdose on these medications as easily as when we were using doses for depression. So what are our doses for depression? We may not even know because we don't even use them anymore. Over 100 milligrams. So again, when we were using these for depression, patients would have 30 tablets of 100 milligrams. That could be something very easily to overdose on. And they were lethal in overdose. So cardiac abnormalities, which were lethal. When we overdose patients with the SSRIs, we give them plenty, 30, 60 tablets of these medications, but the overdose lethality with these are very low. The only one that might give us an issue is citalopram because of the QTC prolongation, because there's that risk of arrhythmias with citalopram, which came out a couple years ago, and why we had the FDA changed the labeling, so no more 60 milligrams of citalopram. So we'll talk about all of these antidepressants. We have a couple new ones, so Vibrid and vortioxetine, and then a new version of Trazodone. So I haven't seen, but we'll talk about all of these. So one of the comments when we got your guys' feedback of what you wanted to learn or this session was, do these medications even work? And they do. We use them because they do work, but we had, I think it was 2009, there's a couple studies in JAMA and New England Journal of Medicine about the bias of antidepressant trials, so that we get all these pro-antidepressant trials, so all these medications that show that they work, but the negative trials very rarely get published. So there's a lot of trials that are completed that never show that the antidepressants didn't work. And so both JAMA and New England Journal of Medicine did large meta-analysis. So they took all of these trials and looked at them. And what they showed was not really surprising to probably many people that work in mental health, that the antidepressants work better in patients with severe or moderately severe depression. In our patients with less severe depression, they may not be as effective as we hoped. So antidepressants work, the meta-analysis, the studies show that they do work in our severe or moderately severe depression. Has anybody heard of the STAR-D trial? I have a former student shaking her head, so proud. So the STAR-D trial was a large NIH study that looked at the sequential treatment of depression. So tried to symbolize what happens or mimic what happens in primary care, what happens when we're treating patients. So what they did was level 1, as everybody that was in the study got citalopram. So they picked just a SSRI, they chose citalopram just as kind of the baseline SSRI that they used. And they saw that 33%, so about a third of patients achieved remission, so had minimal to no symptoms of depression, and then another 10 to 15% had a response. So they may have just needed to stay on the medication a bit longer to achieve remission. The next stage of that trial was what we would do in clinical practice. So if somebody doesn't have remission or response with the first antidepressant, our next step is we could switch. So the patient was switched to sertraline or venlafaxine or bupropion, or they could add on therapy. So they could add bupropion or buspirone. And again, we had about a third of patients achieve remission when they did one of these options. Level 3 was kind of that next stage where we know that we get a lot of patients to this point where they've tried many antidepressants. And with this group, they switched to mirtazapine or nortriptyline, so kind of a third line option, or they added lithium or T3, so thyroid replacement. And so as you can see, like each trial of a medication, as you go, the response or the remission rate decreases, which is probably what we see in clinical practice, where each time we're trying to treat, we get a little less as we go along. Level 4, they got to an MAOI, which again, I have not seen. I think I've seen 2 patients on it. One was when I was at the VA, and one was when I was in residency. So not very common, but again, once they got to this point, another 7 to 10% of patients achieved remission. So it just goes to show, I think, our antidepressants do work. We get about a third of patients respond after level 1, and again after level 2. But it decreases each time. And so one of the things that STAR-D showed, again, with kind of what I mentioned before, was it was our moderately severe or severe depression patients that responded best to medications. So they do work. And the other, I didn't put it on here because I was focused on pharmacotherapy, but the other treatment arm was behavioral therapy. And the patients responded well with the similar results to behavioral therapy. Yeah, and it was also, so the question was alone, so if they could do psychotherapy alone, yes, but they also could do it with medications. So our first big class of medications we'll talk about is the SSRIs. So probably have some good experience with this, very common class of medications to be prescribed, all working to inhibit the reuptake of serotonin, so to keep more of that neurotransmitter in the synapse to hopefully improve that signal across and improve mood. Again, just kind of one of our working theories of what causes depression. Adverse effect-wise, these are the most common ones I see. So some GI, so nausea, vomiting, diarrhea, headache, sexual dysfunction. Do you have other symptoms, side effects that patients complain about when they're taking the SSRIs that you hear commonly in practice? Yeah?
Sometimes it either causes sleepiness or gets people activated so they can't sleep, but I've seen both ends of that.
Yeah. So she had mentioned kind of the insomnia or the kind of the agitation, increased anxiety that we sometimes see with antidepressants. So they can't sleep or makes them sleepy. And there's some differences with medications that we can kind of discuss. It kind of goes back to the gentleman in the back, his comment about using the PHQ-9. So sometimes we can kind of see that come out with the PHQ-9. Any other side effects you commonly see, the SSRIs? They're usually pretty well tolerated for most patients. So these are our usual SSRIs that we're using, and I think this is also in your handout, kind of a little medication table. Paroxetine is one that tends to cause sleepiness, so when I'm giving this to patients or prescribing or counseling patients, I usually recommend that they take it at night if they can, unless they're taking all their medications in the morning, so working with them on how they're going to be best to remember the medication, but if possible, taking it at night can usually help with that kind of groggy sleepiness. The activation, that's most common with the fluoxetine and sertraline. So both of these medications, I usually recommend that patients take them in the morning. Citalopram and escitalopram, these ones, this one gets hard because it gets back to some patients will say it makes them sleepy, some people will say it makes them wide awake. So they really just kind of have to determine how it affects them. I usually, because most patients tend to take their medications in the morning, I usually recommend patients just start with these ones in the morning and kind of see how it affects them. Paroxetine is our one antidepressant that's pregnancy category D, and we'll talk about pregnancy and breastfeeding at the end of the discussion, but that's just something to keep in mind if you're working in primary care and see patients that are pregnant or of childbearing age. And then again, citalopram, I kind of mentioned, this was the max dose used to be 60 milligrams, and a couple years ago it was changed to 40. I don't know if anybody had any clinics, if you guys had to decrease patients, or if you remember, yeah, kind of a headache initially. But there were some concerns about QTC prolongation, which can result in a life-threatening arrhythmia, so that was the issue there. Again, at the bottom, it kind of talks about the class adverse effects to kind of keep in mind with these medications. And then we have a couple of other antidepressants that increase serotonin. So one is Trazodone. So where do you guys mostly see Trazodone? Yeah, so usually sleep. What doses are we usually seeing? You guys see for, yeah, 50 to 100, 25, maybe up to 150, but we're usually not seeing more of that. It's usually at night, mainly for sleep. They did come out with a new formulation, so it's called Electro. Has anybody seen this? No? Anybody at Central City see Electro? No. It came out when I was in residency, and a lot of our psychiatrists I worked with were confused because one of the reasons that they have not used Trazodone for depression was because it caused so much sedation. So they didn't kind of understand the place for Electro. So it's formulated to be extended release. So they just take it once a day. But again, the studies showed high rate of sedation. So I haven't seen it used yet. It's brand only, so it also is quite expensive for patients. So not sure where it would kind of fit in the treatment guidelines or when you would use it in primary care for patients. The two other ones, again, I haven't seen much of these. I'm in Virginia Garcia, where we're trying to, think about cost for a lot of our patients. Is Vibrid and Brilintex. Have anybody seen these ones used? No? Central City? See the new ones? No? So one of the things with Vibrid is I think the hope with this medication with how it works on another serotonin receptor, which the hope was it was going to have less sexual dysfunction. So I think that was kind of the development of this drug. The clinical trials haven't specifically looked for that, so I can't say for sure that it would have less sexual dysfunction, but again, that can be a big issue when we're starting antidepressants, is the sexual dysfunction for patients. So it'll be interesting to see if more information comes out about that medication. So these are kind of just the nitty-gritty on it. Again, I haven't seen them used very much. They aren't technically SSRIs, but they're working to increase serotonin. They just kind of hit a couple different receptors to change their side effect profile a bit. SNRIs, so these are our medications that we're adding another neurotransmitter, so we're adding some norepinephrine reuptake inhibitor to hopefully increase both serotonin and norepinephrine. Very similar side effects to their SSRIs, so some GI, so nausea, sexual dysfunction. With the norepinephrine, we also see some increases in blood pressure and sweating, so just some norepinephrine effects. Probably see a lot of these. Which ones do you guys see most often? Effexor and Cymbalta, yeah. Which other one? Phetsema, a little bit. So Effexor and Cymbalta, been around the longest. Both of them are now generic, so usually pretty affordable for patients. One thing with venlafaxine that makes it a little unique is that it's not an SNRI at all doses. It actually doesn't start inhibiting the reuptake of norepinephrine until we get to doses of maybe 150, but probably closer to 225 milligrams. So I encourage when I'm switching people over or trying to use an SNRI, I keep that in mind that I want to get up the venlafaxine to a little bit higher of a dose. Cymbalta increases norepinephrine at all doses, so there's not that dose titration to get norepinephrine reuptake. Pristiq is the active metabolite of venlafaxine. I don't see it used a lot. Couple reasons: cost, and then also I don't know if you guys have experience with tapering patients off venlafaxine. Can be difficult. It can be a long process because it has some withdrawal side effects for patients, so it's can be a pretty slow process. Pristiq I haven't used for that reason, because it comes in 50 milligrams and 100 milligrams, and I can't wrap my head around how I would titrate somebody off. So I kind of stayed away from it. The other one somebody mentioned they kind of see it is the Phetsema or levomilnacipran. I haven't seen it in clinic. It's the active metabolite of milnacipran or Savella, which is actually used for, do you guys know, fibromyalgia. Dang it, should have made it a trick question. So fibromyalgia, and so we have levomilnacipran. I haven't seen it used mainly, again, because we have our Cymbalta and Effexor that are a little more affordable for patients. But it seems like it's probably getting a little bit more use now as it's been on the market for a couple years. So the other places you'll see a lot of these medications used is neuropathic pain. If they have comorbid diabetic neuropathy, if they also have fibromyalgia and depression, you'll see the SNRIs used a lot. Again, it can be difficult to taper off though. And also blood pressure checks for these medications, especially if you have a patient that you're working with for hypertension or they're coming in for blood pressure checks and they're starting an SNRI, just something to have on your radar that there sometimes can be small increases, usually not huge increases, but a little increase in their blood pressure when they start the medication. So our TCAs kind of alluded to this, that we don't really use them much for depression anymore. Again, they were lethal in overdose. The other big reason is they had a lot more side effects. So our TCAs they're SNRIs for the most part. But the difference between a TCA and an SNRI is that the SNRIs were created with less side effects, so they don't hit as many receptors. So they're not working on anticholinergic receptors, so patients aren't having as much dry mouth, constipation, weight gain, blurred vision, kind of those anticholinergic side effects that we see with TCAs. Again, we do see them. I'm sure you guys see them quite frequently in clinic for neuropathic pain or somebody complaining of insomnia, headache prevention or prophylaxis, so migraine prophylaxis, but the doses are pretty low. Another thing to consider is that there's tertiary and secondary amines. So amitriptyline, imipirine, and doxepin are our tertiary amines, meaning so a couple things. They inhibit the reuptake of both serotonin and norepinephrine, but more side effect-wise, they are able to enter the blood-brain barrier more effectively than our secondary amines, so they can have a lot more of the cognitive side effects. So for our elderly patients, when I'm thinking of starting a TCA, if the patient has neuropathic pain, whichever, I tend to stick with my secondary amines, nortriptyline, just because it has less of that blood-brain barrier that can't get in as quickly, so it can have a little better toleration than our tertiary amines. And for most patients, I tend to avoid the tertiary amines just because of side effect profile. So these are patients, when they're on it, they'll usually complain of that cotton mouth in the morning, constipation. So these are things just to keep on your radar if somebody's on them, side effect-wise, to ask about. Mirtazapine. Do you guys see much mirtazapine? Yes? Okay. Why mirtazapine, do you think? So appetite stimulant. Okay. Sleeping. So works well for insomnia. Anything else? So appetite and sleep. So absolutely. So these are mirtazapine you see used for depression. It's usually not something that somebody goes to initially. I think most clinics are still starting with an SSRI or an SNRI. But you do see it for patients, and we're kind of using the side effects for a positive purpose, I guess. So we mentioned appetite stimulation. So it tends to stimulate appetite, can have weight gain, but that may be something that we need for the patient. Insomnia, so if somebody's really having a hard time with sleeping, this can be an option because it does cause sedation. So dosing it at night. The other interesting thing with, I don't have my little chart, must be in your guys' chart. Mirtazapine is it tends to have less of the sedation and the appetite stimulation with the higher doses. So you'll sometimes see patients that are on 45 milligrams of mirtazapine, and then they've actually switched it to the morning because it's easier for them to remember. It was having no impact on their sleeping, but 15 milligrams, 7.5 milligrams causes more sedation. And that's related to the kinetics of the medication changes. It starts hitting the receptors differently as the dose increases. Pharmacy's fun.
So it's used more for the side effects.
Yeah, like it can be. I think people think of it more because of the appetite stimulation and the causing sedation. Yeah, so also I've seen it used a lot in patients undergoing chemotherapy too in depression because it does have some anti-nausea properties as well. So that is another kind of little niche that you'll see mirtazapine used. Wellbutrin, do you guys see this one a lot? Yeah. Depression, but also smoking cessation. Do you guys still see it for smoking cessation? Have you had patients that were successful with it, with smoking cessation? Yes. Congratulations. So a lot of Wellbutrin. This one, again, we're switching gears a little bit of how it's working. So this one's going to reuptake dopamine and norepinephrine. So a little different. We're not doing the serotonin anymore. So this is a medication, bupropion, you'll see combined with SSRIs a lot. We try to avoid combining SSRIs or combining SSRI and an SNRI because it's a lot of serotonin issues. So when we're looking at combination therapies, you will see Wellbutrin with SSRIs. Side effect-wise, you'll see some of the norepinephrine effects, so the tremor, activation, and then dopamine. You'll see some nausea, some insomnia. I think there it is. This one is contraindicated, so we don't use it in patients that have a history of seizure disorder or in patients that have anorexia or bulimia. And this comes from a couple clinical trials that showed there was an increase in seizures in those patients. So Wellbutrin is one of those medications that's hard because it comes in the immediate release, the sustained release, which is dosed twice a day, and the extended release, which is dosed once a day. And so whenever we get a prescription in the pharmacy, we're always trying to make sure we're filling the right one because we don't want to make a medication error. I tend to use the once a day medication because each time you make somebody take a medication more than once, their adherence goes down dramatically. But the SR was the one that was used for smoking cessation. So most patients that are using it for smoking cessation are taking it twice a day. A counseling point that as a pharmacist I usually make to patients is that if they are taking it twice a day, that they try to take it early in the afternoon. I think patients get drilled into them twice a day means 8 and 8 or 7 and 7. So I counsel patients that if they're taking the wellbutrin twice a day, to take it in the morning, but then try to take it early in the afternoon to limit the effect it's going to have on their sleep. That can be hard for patients. If a patient's taking it twice a day and they're not reporting any problems with their sleep, it's not an issue. But if they're able to take a medication at 3 instead of 8, it can be a good option for them, especially if they're having sleep issues. So some complementary and alternative medicine. So St. Johns Wort. So we're switching gears a little bit. Somebody's shaking their head at St. Johns Wort. That's probably a pharmacist. St. Johns Wort for most pharmacists just signal drug interactions. So that is kind of that initial reaction for most pharmacists when we see St. Johns Wort is, oh no, like what kind of interactions? Are they on other medications? What's going to happen here? I pulled some studies. This is not something that I've done a lot of research on, but as I was preparing this presentation for you guys, I looked into it, and it's used pretty extensively in Europe, apparently, and a lot of the studies come from European countries and shows that it may be effective for that mild to moderate depression. So not necessarily our moderate to severe depression, our patients with those high PHQ-9 scores, but possibly that mild to moderate. Yeah?
What is it?
St. John's Wort?
No, SAME, I'm sorry.
Oh, SAME? That's the next one.
Oh, sorry.
Oh, he's jumping the gun. There's
Oh,
3.
You said used in Europe, so.
Oh, St. John's Wort's also used in Europe. So the SAME and the St. John's Wort seem to be more Europe. And so again, St. John's Wort, our drug interactions scare us. So warfarin, birth control, transplant medication. So if somebody's had a kidney transplant, there's just some interactions there that make us a little nervous as pharmacists. And then avoiding with other antidepressants, because the way it's working for antidepressant is to increase serotonin. So very similar. So, but that is an option. Has anybody had patients that are using St. John's Wort or ask about it?
So I wonder sometimes about the differences between manufacturers
Yeah.
and dosage.
Yeah.
What's
So wondering about differences in manufacturers and dosages. Does anybody else have patients that ask about it or use St. John's Wort? Yeah. And that was the biggest thing when I was looking into it, even from the European studies. And I don't know a lot about Europe and St. John's Wort, but it sounds like it's a little bit more regulated and standardized there as opposed to here. So that was a lot of the conclusions in the studies that I was looking at was, not sure how well this information translates to other countries because they have a very different process for this stuff. And that's the same for the SAME. It's used in Europe as a prescription drug to treat depression. You can buy it here on the herbal supplement shelf. Similar that it's going to increase serotonin, but probably for us to be using it, more research would be needed because we just don't have the same information that they have. Maybe if you go on a European vacation, you can pick some up and it might be helpful. Yeah?
I've had like acupuncturists and Chinese medicine practitioners prescribing it, and even some mental health therapies. I see it more and more.
The SAME.
Uh-huh.
Yeah. I think I've started to see it more as well. Do you guys see it in Central City at all?
We do. Actually, all of our primary care treatment teams have integrated complementary alternative medical providers, at least one represented. So we do see SAME and we see St. John, a little bit of St. John's Wort, but yeah.
Yeah.
Is it a plant product like St. John's?
I think so. I don't do a lot with SAME. The last one on the list is L-methylfolate, which is Deplin. Have you guys seen this one? Some?
Added to Prozac.
Oh, you've seen it added to Prozac?
Secondary therapy.
Yeah, secondary therapy. So this is interesting because it's a medical food, which is strange. I don't know how else to say it. Apparently it needs a prescription, but it's not actually regulated by the FDA. Is that right, Kristen?
Yeah, I mean, Food and Drug Administration, so.
Yeah. And so it's kind of in this little like separate bucket that it's not a prescription, but it's not like a herbal supplement with that regulation. It's kind of somewhere in the middle. Yeah, so it's just a medical food. And so what they say is that they need to be on antidepressant therapy to receive it. And then there's the thought that some patients can't convert folate, and then that may impact their depression. So this is kind of the active form of folate. I haven't seen it used in clinic, Central City.
I've seen it used once.
Once.
Successfully. Yeah.
Successfully.
So, yeah.
And I don't know if insurance covers it.
No, it's not a drug.
Yeah, so it's not a drug, but you need a prescription to get it, but it doesn't have an NDC number. So it's kind of this weird enigma of thing. So it's supposed to be, so it's very strange. It has to be not prescribed, but under the medical supervision. So it's usually behind the pharmacy. But I think there's OTC variations of it, but it wouldn't be Deplin, but it would still be L-methylfolate. It's very strange. So we have recommended antidepressant combinations. So probably you've seen some of these. So a patient on an SSRI or an SNRI plus wellbutrin. Some ideas when you see this used is sometimes patients that have low fatigue, or patients that are having sexual side effects from their medication. Wellbutrin tends to not have sexual side effects, probably related that it's not impacting serotonin. As a pharmacist, this is not my favorite thing to treat a side effect with a medication, but if somebody's having a really good response to their SSRI and SNRI therapy, like they're in remission, but their biggest complaint is that the medication's causing sexual dysfunction, this may be an appropriate option because the patient's achieved a remission, things are going well, but the medication's causing a side effect that is not ideal. A lot of other times you see an SSRI with Trazodone. Again, it's probably going to give that same warning of serotonin syndrome or too much serotonin. Used very frequently in clinical practice, and with low doses of Trazodone, it seems that we're not impacting serotonin to the extent of being dangerous. Also see SSRI or SNRI plus Mirtazapine. Have you guys seen this combination much? Yeah, so this can be a common combination. Again, can be an option where they're having a partial response or a pretty good response, but still maybe having trouble with their appetite, maybe having a lot of insomnia, so Mirtazapine can assist, and also sexual dysfunction. And then the TCA, this combination is mainly not so much for depression, but a combination that you'll see if somebody has depression and neuropathic pain. And we're using low doses at bedtime. Tricyclic antidepressant, sorry. My bad abbreviation. So with you guys in primary care, how do we select the right antidepressant? What has been your experience when patients are started on an antidepressant? How did they start on that one? Anything?
What have they already tried before?
Okay, yeah, so what have they already tried before? Which can be hard. A lot of patients have tried a lot of medications. They may not remember all the names of them or what happened. So I usually start out with that question, but then if they're like, I don't remember, I'll usually then follow up with, well, is there anything that you would never take again? They usually have one or two where they're like, no, that was awful. I would never take X drug again. I hated it. Okay. Well, is there anything that you remember worked really well, or you think back and you're trying to remember why you stopped it? And so that can be another option. The other one is family history. So I talked about that there's probably a large genetic component with depression. So that can be a starting place for somebody if they're newly diagnosed with depression, if they have a family member that was successful with the treatment, to start with something that worked for them, if it seems like the right one for the patient. There's a lot of other factors to consider with that, but at least a starting point. Side effects to your advantage, so talked a little bit about that, specifically with Mirtazapine can be a good option. The paroxetine, possibly. The thing to mention with paroxetine is that's another one that can be hard to withdraw from. Has a little bit more anticholinergic side effects, so be careful with that one. Prozac can be a good option for patients if they kind of struggle with taking their medication every day. It has a longer half-life, so they don't have that withdrawal if they miss a dose, but encourage them to take it every day. It's going to work better. Comorbidities and current medication, so that comes into the pharmacy side of things, drug interactions, but looking to see if the patient has fibromyalgia or neuropathic pain, where maybe an SNRI would be a good starting place for that patient, or wants to quit smoking, maybe wellbutrin would be a good starting point for that patient. Patient preference, again, that's a great starting point. Ask the patient, is there something that, you've talked to somebody and, you'd be interested in trying. You had a friend that had a really good response with the medication. You've done your own research and you come in and you think, what, I think venlafaxine is something I would be interested in trying, and have that discussion with the patient. Medication cost can be a big issue. Most of our antidepressants are generic, so they can be affordable, but we don't always know what's affordable to patients, so don't assume that $4 is going to work for them, or $1 is going to work for them. And some of our medications are brand. That can be an issue. Talked about the buckets, so it gets difficult with insurance, especially Medicaid, because they're still carved out, right? Yeah, so they're in a whole, DMAP is covering those, so usually they're pretty affordable for patients. A little bit about adjunct treatment. So seeing more of the second generation antipsychotics. Have you guys seen this used in primary care? A little bit. I haven't seen it used much in our primary care clinic. I think just comfort level for our prescribers, but you will see the second generation antipsychotics added on to antidepressant therapy. Probably, well, which one do you guys see most? Quetiapine? Olanzapine? See a lot of Abilify, so I think I got all three of them. The other two, the lithium and the thyroid, so not FDA approved, but these are ones sometimes we'll see added on. Specifically saw them when like the STAR-D trial came out, because there was some evidence that they could get to remission with these medications. Lithium, we're not using the doses that you would use in the treatment of bipolar with patients, but still the same monitoring with it. So still checking blood levels, still checking TSH, still checking renal function, but not going up the dose that you would use in bipolar. And then thyroid supplementation, not FDA approved, but one of the first slides was ruling out medical conditions. So patients with depression, our clinic does a pretty good job of always checking thyroid to make sure that they're not hypothyroid, that they don't just need thyroid supplementation. So adolescents, this is just a quick information about them. We heard from our patient that depression started for him when he was 8 years old. So increased risk of substance abuse, attempted and completed suicide, and depression for depression with children and adolescents. We do have medications that we use for depression. Pretty much all the SSRIs are used, but just ones that are approved is fluoxetine and escitalopram are FDA approved for children and adolescents. And then sertraline and citalopram are second line. They're not FDA approved. That doesn't make it inappropriate to prescribe these to adolescents, especially when sertraline is used in 6 or older for OCD specifically. Do your clinics prescribe many antidepressants to the children or adolescents? Or are they referring them out to child psych? Yeah, most of our clinic tends to as well. So depression and pregnancy, so primary care-wise, probably see a little bit of this in your clinics depending. Some people had mentioned it. Already mentioned some of the past risk factors. So if they had a history of depression, unplanned pregnancy, single, social support system, those can all be risk factors for developing postpartum or depression during pregnancy. you guys probably know this is why we screen for it, because there can be risks to both the mother and the fetus if the depression's untreated for the mother. So mainly the risk to the fetus is the premature birth, low birth weight, or small for gestational age. Probably related, if the mother's not being treated, may not be following up with appointments or taking the prenatal vitamins or keeping up with her care. So if we're using medications in pregnancy, one of the things, for all medications, we're usually trying to avoid the first trimester. So much growth is happening. What's the difficulty avoiding in the first trimester? Yeah, most pregnancies are not planned. Most patients are already through the first trimester or pretty far along in the first trimester if they're on the medication already. We want to use monotherapy whenever possible, use the lowest effective dose, and then we can use the PHQ-9 or the Edinburgh Postnatal Depression Scale. So for antidepressants in pregnancy, just an idea of ones that you will see in pregnancy. I don't know which, if you guys have pregnant patients with depression, what do you guys see used? Prozac the most. Anybody else? Zoloft, sertraline. Those are the two that I see most frequently as well, is Prozac or sertraline. Fluoxetine or Prozac has the most evidence or most studied. Paroxetine, again, probably should be avoided. It's got that pregnancy category D risk. Might have changed now because they just updated the pregnancy categories. But there's some heart and septal defects that could be an issue for the fetus. Yeah?
I've been reading some recent articles about sertraline having a pulmonary hypertension effect on infants. Can you speak to that?
About sertraline having pulmonary hypertension. Yeah, there was a meta-analysis with all the antidepressants. I haven't looked at it specifically, but it's kind of a class risk of pulmonary hypertension. But it's hard to categorize if one has more risk than the other. Yeah. So postpartum depression, it sounds like this is probably a priority in primary care. Yes. So 10 to 15% of new mothers will satisfy the criteria for acute episode of major depression and low treatment rates. So we've got the baby blues versus postpartum depression. So I think, what has your guys' experience been with postpartum depression in the clinic? You see it frequently? Do you think the clinics do a good job of screening for it? Yes? No? Sometimes? Yes? I have a 10.5-month-old, and I have Kaiser insurance, and I was impressed with what they did, because at the 2-week check, they gave me my little questionnaire, and then at my 6-week check, and then at her 12-month check. So when I went to her 3-month appointment, her pediatrician, I had a PHQ-9 that I filled out. So Kaiser, I think, did a good job of screening for it, but I think it's really important to look at, because that bonding with the infant, as well as kind of that those first couple weeks, can be really hard, I learned personally. So those baby blues were definitely a real thing. It was not expected how much flood of emotions happen after you leave that hospital. But as somebody mentioned, that first 12 months can still be that period for postpartum depression. So I think keeping that in mind, as you guys do in primary care, of continuing to ask the mother. Antidepressants and breastfeeding. So really encourage breastfeeding for most clinics, I think, do a pretty good job of that. But also, if they are on an antidepressant, reassuring them that it's safe to breastfeed with their antidepressant. So preferred SSRI, sertraline is one. I think that's why a lot of patients get started on it during pregnancy. It's just because then they can continue it on through breastfeeding. So very common, minimal to no detectable levels in breast milk. Very few medications pass into the breast milk, so pretty safe option for the infant. Bupropion and duloxetine also show very little infant levels. Fluoxetine and venlafaxine can have some levels, but again, low risk for any side effects to the infant. So main point, like antidepressant therapy is not a reason for the mother to quit breastfeeding or have to pump and dump her breast milk or anything like that. Depression in the elderly, we talked about that kind of bimodal distribution of specifically the suicide. So this can be a risk factor in our elderly patients of completed suicides. And they can present with a little bit of different presentation. And also knowing that depression is not a normal part of aging. They should still be checked for depression and treated if they're having depression. There's another depression scale. There's a geriatric depression scale as opposed to the PHQ-9, where the geriatric depression scale, I don't know if it's in your books, but you can print it off, but it has more just yes or no questions, which may be easier depending on education level. So SSRIs are usually first line in geriatrics. Just some things to monitor or keep in mind if we're starting these. These medications can decrease sodium. Tends to happen more in our elderly patients, so monitoring for hyponatremia can be a big piece. The other thing, the SSRIs, I don't know if you guys have heard about this, but increasing bleeding risk, specifically in our geriatric population. So patients that are on SSRIs or NSAIDs or other medications that can increase GI bleeds, that's something to kind of watch out for and see if we need to adjust medications or do something to protect them from getting any complication from that. And usually kind of the mantra for treating geriatric patients is start low and go slow. It's the same with our antidepressants. Usually start at a little lower dose and kind of titrate it slowly. And many of you have mentioned how you use the PHQ-9, but depression with comorbid disease, so physical illnesses. So very common with diabetes. I'm sure you guys have seen that. What's the impact of depression and diabetes? What do you see happening in clinics with patients with depression and diabetes?
It's a chronic illness, so it's all the things that go with no solution. No, it's not going to resolve. Mm-hmm. So some of that hopelessness, or how do you learn to manage?
Yeah, so hopelessness or how you learn to manage your diabetes can have decreased adherence, just not that, not wanting to check your blood sugars, not wanting to inject your insulin, not wanting to do these things. So, hypertension can be the same, not wanting to check your blood pressure, not wanting to deal with taking these medications. It can be overwhelming. So there's a high comorbidity with diabetes, which you guys are all aware of. So some side effect management when patient has good response. So the wait and see approach. So if somebody's responding really well to their antidepressant, but they're having side effects, if it's within the first 1 or 2 weeks, hopefully kind of counseling them through that, letting them know that, we can adjust therapy, but usually those side effects will go away. Your body kind of has to adjust, so it may be decreasing therapy, wait and see if things start to improve. Change medication dose or timing. So some people mentioned this specifically with insomnia. So finding out when they're taking their medication, seeing if we need to change it to the morning. Drowsiness, they're taking it in the morning, try and take it at night. Or trial decrease in dose. So see if decreasing the dose can kind of improve the side effects for the patient. Sexual dysfunction. Do you guys talk to your patients about sexual dysfunction with SSRIs? Big thing. I guess, how do you ask them? Kind of similar to the suicide question. How are you asking patients about sexual dysfunction? Yeah?
I would just say, it's pretty common to have some sexual side effects with these medications. What's your experience with that? Are you noticing?
Yeah, so
normalize.
Yeah, normalizing again. So common side effect of this medication can be sexual dysfunction. So difficulty maintaining or achieving an erection, difficulty with orgasm, decreased libido. So all of those things can be normal side effects from these medications. What has your experience been, or has anything happened that we need to talk about? One, with the sexual dysfunction, some approaches are wait 6 weeks, because that seems to be where that side effect may or may not improve if that's reasonable for them in their relationship. Trial a dose decrease again, looking to see if Maybe just not inhibiting so much serotonin can help. Again, if they have that good response to treatment, one option is the addition of wellbutrin, because it does have less sexual side effects, but again, not the best to treat a side effect from a medication with another medication, but it's an option for patients. If patients aren't responding to treatment, a lot of these questions can come in handy if you're titrating medications or following up. So do they have an adequate trial length, so 4 to 6 weeks, adequate dose? That's one thing I see is they get started on 25 milligrams of sertraline, but never get titrated up to a dose that probably will be effective. Patient adherence, so are they taking their medication every day? Did they stop taking it after that 12 weeks because they were feeling better and now they have relapsed for another depressive episode? Adverse effects, you can't blame somebody to stop taking their medication if it was causing them to be sick or impacting their relationship because they had sexual dysfunction. That's a reason to stop your medications. Drug interactions, or are they on a medication that maybe is decreasing the effectiveness of their antidepressant, so maybe they need a higher dose because of that drug interaction. Correct diagnosis, again that goes back to the provider to see is something else going on. Psychosocial factors, do they have a good support system, are they engaged in therapy, or other comorbidities. And again, as a pharmacist, we do want patients to get off their medications. So stopping treatment safely, I think this comes up a lot in one of the first conversations when I'm seeing patients, is letting them know that I'm fine if they want to stop their antidepressant, but I want them to do it safely and can help them do that so that, one, their depression doesn't come back and they don't have withdrawal side effects from these medications. So encouraging them to at least stay on the medication for that 6 months and then looking to see if it would be an appropriate time to titrate off. This kind of helps to decrease the risk of recurrence of their depression. If they were on a high dose of sertraline and we tapered down, has their depressive episodes come back? Are they getting some more symptoms? Do we need to go back? It wasn't the right time to stop their antidepressant. Or is the patient a candidate for maintenance treatment? Have they had multiple episodes, severe depression, suicide attempts? Maybe they need to stay on it a bit longer than that 6 months or 9 months. It might be a year, it might be a couple years. And tapering off, again, withdrawal symptoms. So the easiest way to taper off is just taper back down how you got on the medication. So if they were on sertraline and they started at 50 and got to 100 and 150, go down to 100, go down to 50, and then stop the medication. Again, we try to avoid premature discontinuation because each time we do that, their risk of relapse and recurrence of symptoms increases. And when to seek that referral. So suicidal thoughts, again, that I think we already discussed how important it is to ask this question and don't just accept that yes or no. The PHQ-9, again, that has that checkbox of, how often are you having suicidal thoughts? So that can be a starting point to have that discussion. But going through those questions and then not leaving the person in the room. So it's just something I think most clinics have that as a policy, to not leave a patient that is expressing suicidal thoughts in the room by themselves. So if you have a phone, or you can just step out the door to get somebody to come into the room with you. We're lucky that we have behavioral health therapists in our clinic, so we usually can do a warm handoff and somebody can come and talk with them. Psychosis, so there can be psychotic depressions. Patients can have really severe depression where they're having hearing voices or hallucinations or psychosis, so that would probably not be the best place for primary care. So figuring out where the referral place is for them. And then if they've had a lot of failed treatments, maybe they need some step up in therapy and need to talk to somebody with a little bit more expertise, like a psychiatrist. We also, so there's Multnomah County. NAMI also has NAMI in Washington County, in Aloha, which is also very active and has a great center, and it's pretty much open all the time. They have a garden, they have art therapy, music therapy, all sorts of things for patients. So that if you're in Washington County, that's a great option for patients. If you have patients that live in Aloha, Beaverton, Hillsboro, it's right on TV Highway. And now you get to ask questions.
Bridget.
Thank you.